we look at breast, it says 249,000, that's about 250,000. Those are the invasive cancers. If you add in the in situ cancers, that's going to be another 70 to 100,000. So we're talking about 300 to 350,000 new breast cancers a year. And very few are in men, only 2,600 in men, so vast majority are in women. And we have about 40,000 deaths per year. So the incidence continues to increase as the baby boom generation gets into the ages where they're more likely to have breast cancer, because breast cancer is an age-related phenomenon. In general, the most common types. And we have a little less than 3,000 a year, 2,760 predicted for Oklahoma for this year. So, we've looked at that data. When we say estimated number of new cancer deaths, guess what? That's coming from the CDC data. Even though the American Cancer Society put it out, it's coming from the CDC data because that's where the incidence data comes from. So it's an interesting collection, an admixture when you get cancer publications where the data comes from. All right, how does breast cancer present? This is a common thing. You read about this in, Ladies Home Journal and Women's Day and all the women's magazines, particularly in September and October. So what are the presentations for breast cancer? Okay. A lump.
Weight loss?
Nope. Weight gain is associated with breast cancer. That's a trick question. Weight gain. If few cancers cause you to gain weight, breast cancer is one of them.
You get the lymph nodes in your armpits?
That would be a lump.
Breast soreness, or tenderness,
Not unless it's associated with lump.
Nipple abnormalities,
Nipple discharge. This is the third one.
thickness and swelling,
Still, only if it's associated with lump.
Redness and warm.
Only if it's associated with lump.
Dimpling?
Associated with lump.
Bone pain?
Hmm?
Bone pain?
It's metastatic disease. We hope we find it before it's there.
General fatigue maybe?
Screening abnormality. There's been lots of money in this country screening women with mammography, right? The current standards for most of the professional organizations is annual from age 40 and up. We'll talk about that later. We'll get into the controversy stuff later on. But a screened abnormality, which usually means calcifications, which are formed in response to inflammation, usually an obstructed duct at some point, or mammographic appearance of a lump. Usually the lumps are scurous, so that means they're scar forming and scar sticking in behavior. Since most fibroblasts in the breast come from the Cooper's ligaments, it'll be like lassoing the Cooper's ligaments together, which means spiculation. The Cooper's ligaments carry with them a lymphatic and a perforator up to the skin. If you obstruct the perforator, you get called orange edema. You get over-distension of the skin, you get the erythema. You get foreshortening of the Cooper's ligaments, that's dimpling. It's all just where the fibroblasts came from that are reacting to the tumor. Which means, to get any of those things, the body has to decide the tumor is something it doesn't want there, get an immunologic response to it, and then you see it. Guess what? A mammogram of a non-scurous breast cancer and normal breast tissue look exactly the same. What a mammogram is looking for is the scar response to the inflammation caused by breast cancer, which tells you this isn't like pap smear where you're actually looking at the first changes. We're looking at something that happened late in the course and evolution of breast cancer, which is one of the issues with screening mammography is it may take 10 to 20 years for the lesion to be visible on mammogram, By the time it's visible on mammogram, you're within 14 months of it being palpable. So you've got a small lead time bias offered by your screening approach. Not like pap smear, where you may be detecting the very earliest changes before they even progress to cancer. So it's not an ideal screening test, that's why the controversy exists. All right, if you have somebody present with any of these things, we need to know some history information. That's the first thing you do, right? Do the patient has some history. There are 7 factors associated with greater than 1.3 relative risk for an increased risk in a woman's lifespan in this country for the development of breast cancer. These 7 factors are known as the Gale model. And in fact, there are many things you can download onto your computer, your cell phones, etc., the Gale model, and do the Gale risk estimator. So the things to determine risk that are most important, the questions that must always be in an evaluation when you evaluate somebody for a breast problem are what? What are the 7 things? All right. Family history is number 5, and the only one that will make a 1.3 relative risk increase will be first-degree relative, so within 1 generation. Doesn't matter whether male or female, just within 1 generation. All right. Next.
Previous breast cancer?
Well, that doesn't affect enough people. Let's expand this to the whole population. What's something we can say with the whole population?
Previous cancer?
Ah. Well, I'll give you one, these last 2 are linked. I'll give you one of them because it's not obvious. It's the number of breast biopsies. And then if you had ADH, ALH, anything substantially proliferative. So does breast biopsy cause breast cancer? We don't think so, because there's not an increased incidence in the same quadrant where the biopsy was done. It's not temporarily related to when the biopsy was done. In laboratory animals, we've never been able to show that biopsy causes breast cancer. Let me point out to you, put a piece of saran wrap under a mouse's skin, you can get a sarcoma. So it's not completely implausible that it might. We just got no evidence to support it. However, if you're lucky enough to get a breast biopsy, you almost always have substantial proliferative disease, even if the pathologist didn't see it on the microscope slide. So it's a predictor of proliferative abnormalities within the breast. Okay. I've already mentioned one. Talked about baby boomers. Age. So the first inflection point in the curve is between 32 and 35. There's another one about 40. The biggest inflection point is around menopause. The surrogate for menopause in most studies is going to be age 50. And then it increases each decade of life to level off a little bit in the 9th decade. So it is very much a disease of aging. It starts much earlier than the other hormonally induced malignancy, prostate cancer. So it's spread over a longer time period than prostate. All right.
Genetics,
Genetics.
like BRC.
That would be family history.
Okay.
Increase estrogen.
Okay, let's go at the increased estrogen thing. What increases your lifetime endogenous estrogen exposure?
Birth control.
Obesity.
Endogenous, not exogenous.
Obesity.
Oral contraceptive is exogenous, sometimes endogenous. Age of menarche, right? Earlier age of menarche, greater the risk. Menopause, late risk of menopause, late menopause is actually only 1.2, so it's not quite there. Postmenopausal hormonal replacement therapy is 1.24, so again, not quite high enough to meet the standard of 1.3 relative risk. However, nulliparity dramatically increases risk. How do we make null parity apply to everybody, every woman in the population?
Never having breastfed?
No. The prima gravida age. And the number that actually goes in the formula, you put in prima gravida, but the number that goes in the calculation is prima gravida age minus menarche. So it's the number of unopposed menstrual cycles prior to a maturational event. So a full-term pregnancy is a maturational event. Prolonged breastfeeding makes it a more profound maturational event. But if you're nulliparous and you're 72, then the prima gravida age that you put in the formula would be 72. But if your prima gravida age, your menarche is age 13, prima gravida is age 15, you're going to be pretty low for risk for breast cancer. If menarche is age 9 and your prima gravida age is 38, you're going to be high for breast cancer. All right, that leaves us with one. Is breast cancer an EEOC, an equal opportunity employer? Well, we're saying this is just in women.
Your race?
Race and ethnicity. So, what race is the highest risk?
Caucasian.
What race is the lowest risk?
Asian.
Correct.
Okay.
Amongst Caucasians, what ethnicity has the highest risk? I'll give you a hint, Tay-Sachs.
Jewish.
Ashkenazi Jewish. Ashkenazi Jewish. Eastern European Jewish. Because between 1200 and 1400, there was a series of ethnic pogroms between the Roman Catholic Church on the German side and the Russian Orthodox Church on the Russian side that caused the ultra-Orthodox communities to isolate themselves and interbreed for several generations, and guess what? We had some cluster mutations, BRCA1 and 2 cluster mutations being likely. And that's where Tay-Sachs and several other things appear. A lot of people tried to lose their Jewishness between 1400 and 1800. So they intermarried and became Christian, etc. So a lot of people with Northern European, particularly East Germany, Poland, that sort of stuff, we have an ancestor that's Jewish they don't know about. So the incidence of BRCA1 and 2 mutations is higher there. But BRCA1 and 2 mutations happen anywhere where cousins marry cousins for several generations. So where is the cluster point in Oklahoma? I talked to a bunch of Oklahomans, right? Where is the cluster point in Oklahoma for BRCA1 and 2 mutations? South and east of McAllister. Hope nobody's from there, but it. All right, but that's our little local cluster point, but it happens to be anywhere where this happens, anywhere in the world. All right, so you answer these questions and you put them in the formula and it'll tell you what the 5-year, 10-year, and lifetime risk for the development of breast cancer is. So you get to figure out how high risk the patient is prior to the onset of whatever their symptom is or presentation is. That also will impact what their future risk is for a second and third event, because some women don't have just one breast cancer, they can have more. All right, if we have a lump, what do we do to make the diagnosis? What do we do before biopsy? We take a mammogram. And what's the difference between a screening mammogram and a diagnostic mammogram? Okay, screening mammogram, you're supposed to be completely asymptomatic and low risk. They compress the breast, CC and MLO. MLO is in the angle of the fibers, the pec major. So it's not exactly 90 degrees to each other. If you think about that, that means the high upper inner breast and the lower outer breast will never be in the mammogram film. Therefore, they're unscreened by mammography. which is where you need to pay close attention on clinical exam. Right behind the nipple, which doesn't get flattened out quite as well, when you have a lot of crowding of ductal markings, that's also an area that can be silent on mammography. Okay, so CC and MLO, so you get 4 films per patient. You have to compare to last year's film, so that'll be 8 films you have to look at. For every 1,000 screening mammograms, there may be 1 or 2 films that has a cancer. This is a big game of finding Waldo. So they're batch read by radiologists in a dark room, it's quiet, nobody around, when they're well rested, and eye fatigue can be a big issue. So we have digital mammography now so that we can get a pre-screen by the computer to draw the radiologist's attention back to certain areas that look a little bit funny. But that's a lot of mammography, find 1 or 2. For every 1,000 mammograms, 100 women will get a call back for a diagnostic mammogram, where they take films and the radiologist reads it while the patient's there, and they keep working at it until they get a diagnosis or do a biopsy. And of the 100 that get called back, about 10 to 12 will be biopsied, and 10 to 12 to get biopsied, 1 will have cancer. So we do a lot of work, and we do a lot of biopsies for every cancer we find. We have over 1.8 million breast biopsies done per year in the United States. The breast biopsy miss rate of a cancer for surgical excision of a palpable lump, which would be the very best biopsy we could do, is 1 in 50. So core biopsy of a mammographic lesion, where you might get the needle right in front of or right behind the lesion, but not really with parallax issues, not really in the lesion, going to be a higher miss rate. If you think about that 250,000 women with invasive breast cancer, there's a lot of them that have missed core biopsy. But you try to prove that you're taking a piece of the tissue that you're interested in. Oftentimes, we use ultrasound because you can tell cyst from solid. You can also tell better when you're doing the biopsy that you're actually dead in the middle of the lesion, because you can kind of do 3D imaging, moving the ultrasound probe around while you're doing it. And we usually are going to do some sort of core biopsy. And if the core biopsy does not give us something we think is likely to explain the lesion, then all of those have to come to surgical excision. The core biopsies are 2 millimeters in diameter, about 1.5 centimeters to 2 centimeters long. The difference between atypical ductal hyperplasia and ductal carcinoma in situ is 2 millimeters per lesion. So guess what? You can't tell the difference between ADH and DCIS. So any funny proliferative thing has to come to open surgical excision. So think about breast, 3 data sources. It's also belt and suspenders times 2. It's 3 lines of evidence. So if your mammogram, you look funny, you repeat it, you think it's benign, and the clinical exam is benign, that's only 2 lines of evidence. So you're going to have to repeat another mammogram in 6 months to make sure the lesion hasn't changed. Then you got your 3 lines of evidence, you don't need to biopsy. If you can't provide 3 lines of evidence that it's not a cancer, you need to biopsy. So that's why there's such a low threshold for biopsy. The mammogram doesn't really tell you whether or not to biopsy the lump. The purpose of the mammogram is to find out if there's something other than a lump there that you need to also pay attention to. If you have a lump, even if you don't see it in the mammogram, you still have to biopsy. Now, the ultrasound might tell you it's a cyst, you don't need to worry about it, but the mammogram is unlikely to tell you that. All right, now we have prognostic and predictive. When we do a biopsy, we're going to want certain pieces of information that tell us about the prognosis of the cancer. When we say prognostic factor in oncology, it means something very specific. It's kind of like sensitivity and specificity in statistics. Prognostic factor is, it tells us about the prognosis of the patient independent of how we treat the patient, what the outcome is going to be. There are predictive factors, which are prognostic factors that we can alter with treatment. We can change the outcome by changing our treatment. So, what are the 4 prognostic factors for breast? I'll give you a hint, the same 4 for prostate.
Surgery?
No. Prognostic factors. Prior to surgery, what can we tell you about the outcome?
Size.
T,
Good spread.
N, nodes, M, metastases, T and M staging, right? And then, what's the final one? Grade. It's sometimes called modified Bloom-Richardson grading in the US. It's usually everywhere else in the world called Elston grading for breast. And you know you have grading in prostate, right? So the 2 most common malignancies, we have reproducible pathologic grade that tells us something about prognosis. Nowhere else do we have reproducible pathologic grading yet. People are still trying to get that. We don't quite have it. All right, T. T0, or TIS, is going to be in situ carcinoma. LCIS is just a high-risk lesion, which imparts a 1% per year risk for the future development of breast cancer on either breast. DCIS is an obligate precursor to invasive ductal breast cancer, although the rate of progression is quite slow. It's in 2 to 5% per year. So, finding DCIS in an 82-year-old in a nursing home is probably not a clinically relevant event. Therefore, most people would say most 82-year-olds in nursing homes do not need the mammograms. They do not need the field trip to mammography. That would be the reason why. You're not going to find something you're going to change the outcome. All right. T1 is invasive cancer from any size up to 20 millimeters. 20 to 50 millimeters is T2, above 50 is T3, and T4 is any grave sign. The grave signs are those things which were associated with no therapeutic benefit for a radical mastectomy back in 1920 and 1930. And they are erythema, edema, satellite lesions, so Earth and Moon kind of thing, or fixation to the chest wall, any other muscle than pec major or pec minor. And the reason the difference is pec major and pec minor have the same lymphatic drainage as the breast. All the other chest wall muscles, intercostal, serratus, latissimus, have a different lymphatic drainage. So they have a different prognosis. So, T4 are the worst, they're the inoperables. Nodes, 0 is no nodes, 1 to 3 is N1, 4 and above is N2. Pathologic, clinically it's matted versus single nodes. And metastasis is just 0 or 1, positive or not. N3 got added more recently. It's a regional node, extended regional node, so it would be like an internal mammary node or superclav node, but not an axillary node, so it's extended regional. All right, predictive factors. What are some things will help us in terms of treatment? Estrogen, progesterone, right? So estrogen receptor, progesterone receptor, that tells us if the patient's hormonally sensitive. We have anti-estrogen therapies that we could use to stop growth. The third one, anybody ever heard of Herceptin? No? Okay. HER2/neu is a transmembrane expressed glycoprotein to the tyrosine kinase family that sticks its glycoprotein arm out the cell membrane. A mouse monoclonal antibody in the late 80s was developed against that glycoprotein, and it was found that patients who had breast cancers that expressed that in increased concentrations had a much worse prognosis. That mouse monoclonal protein was eventually developed into an adoptive immunotherapy against breast cancer. We anticipated when we gave it to patients they would be able to reject their own breast cancer. Well, guess what? Had virtually no effect when given by itself. But if you started giving it with chemo, you took one of the worst prognosis breast cancers and made it one of the best prognosis breast cancers. So things don't work out the way you planned. This glycoprotein sticks its arm out of the cell membrane right next door to the multi-drug resistance pump, which is the way most cells avoid the effect of chemo. They pump out it as if it's a toxin and keep the concentration low enough in the cytoplasm they don't die. Guess what? If you get this immunologic response to the HER2 protein, you gum up the multi-drug resistance pump and those cells become super chemosensitive, which is why the two together work super well, but it alone did very little. Once you present antigen so quickly from killing the tumor off so quickly, you mount an immune response which you can maintain by giving the patient the mouse monoclonal antibody for several months after the chemo ends. So most people get Herceptin now if you're HER2 positive for a year. So it started with your last chemo and given for a year afterwards. HER2 is not expressed in the adult in any autopsy information we can find anywhere, but it's expressed in the embryonic heart. So Herceptin actually has a small but real incidence of heart failure, probably because there's a tiny bit of expression in some heart muscle that we can't detect. So, not particularly the safest thing in the world, not quite as safe as the flu vaccine. All right, ERPR HER2, there's something called Ki-67. That is a proliferation marker. It builds up in late S and G2 and disappears between prophase and metaphase. So we think it's a pre-spindle protein. But it's just a way to tell how fast the cells are growing. The higher the percent Ki-67, the more proliferative activity in the breast cancer, the worse the prognosis. And incidentally, perhaps the more sensitive they are to both chemo and radiation, which both work by tumors growing quickly. So it can help us out a little bit. And the last thing is a gene array. And this is where we look at the genes expressed by the tumor to decide what drugs we're going to use to target all the ways the tumor grows. And that allows us to plan our treatment better. All right. So, any cancer treatment, there are 4 components: local, regional, systemic, and survivorship or prevention. A lot of cancers we know very little about survivorship and prevention. We actually do know some in breast, so that's good. So, local treatments. What are the local treatments that women have for breast cancer? There are 2. Your grandmother can answer this question, so you should be able to. Local treatment.
Oh.
Breast. What do we do to the breast?
Take it off.
Okay. Mastectomy. And most women today do not get a mastectomy. What do they get?
Radiation.
They get lumpectomy. Right? And the treatment is actually lumpectomy plus radiation. Lumpectomy and axillary dissection was the treatment Theodore Billroth proposed for breast cancer in the 1850s. It had over an 80% in breast failure rate within 3 years. So when December the 11th, 1892, in the Bulletin of Johns Hopkins Hospital, William Stewart Halstead reported treatment of 60 cases of cancer of the breast with a 6% 3-year failure rate. local failure rate. That was the operation that swept the world, modified radical mastectomy. And it's the operation that identified the prognostic factors were size, nodes, metastases. So it's actually where we got staging from, even though it took us to the 1950s to prove that staging was important. He actually proposed it in that first article. That's where mastectomy comes from. We're doing less today in terms of mastectomy than they did even 20 or 30 years ago, but we're still trying to remove 95 to 97% of breast tissue. So for most women, it's virtually an amputation. Lumpectomy is defined as, unlike Billroth, it's defined in Halstedian terms, is removal of the tumor with a rim of perfectly normal breast tissue in all directions beyond pathologic doubt. So we don't have to have very many millimeters, but the pathologist needs to be able to say, on the basis of what you gave me, it's very unlikely there's any residual in that breast. That's really the standard for lumpectomy. And we're achieving our margin that we achieve in mastectomy by substituting radiation for additional surgery. But the amount of tissue treated is actually greater in lumpectomy and radiation than it is in mastectomy. So between the two, breast conservation is the more aggressive operation, which is not intuitively obvious. But that's why survival is sometimes slightly higher for breast conservation. It's just treating a bigger area and more volume of tissue. Okay, regional. Regional would be 80% of breast cancer spread first to the axilla. So it's dealing with the axilla. We now do sentinel node. If you're node negative, clinically, if you're node positive, we do an axillary dissection. We used to always do an axillary dissection. We figured out there was no added benefit of prophylactically removing uninvolved lymph nodes. There's only a benefit if they're clinically positive. So we began to say we still need the information from the axilla because it tells us a lot about the prognosis and who needs a lot of additional treatment. So how do we comb that down? Halsted, when he was defining the radical mastectomy, used methylene blue and injected around the tumor and saw every lymphatic and where it went, and he took all those lymphatics in all directions with the specimen to try to get ahead of the breast cancer. Today, we inject lymphojurin, which is related to methylene blue, and just take out the lymph node that gets it first. The 1, 2, or 3 lymph nodes that get the lymphojurin first. So we're actually kind of doing what Halsted did, but doing it combed down to the specific case instead of doing every possible pathway. All right. Gives us important prognostic information. If it's clinically positive, we have to dissect the axilla. And the bigger the burden, we may add radiation. And again, if you have a large number of nodes possible underneath the armpit, you worry about nodes underneath the clavicle going up into the neck, so you add radiation to add that in. If you have lymph nodes here, but you have a medial tumor, you worry about internal mammary nodes. You radiate the internal mammary nodes instead of having to take them out. So anywhere we're concerned about surgical margin, we add radiation to expand the margin. All right, systemic therapy. We have hormonal therapies. So premenopausal, we have tamoxifen. Tamoxifen is a synthetic estrogen. It was developed by the Imperial Chemical Corporation in Britain at the request of MI5 and MI6 toward the end of World War II because they wanted a sex steroid related to estrogen that they could aerosolize over German troops in battle and make them fight less aggressively. 2 things were developed out of that thing. Both made it into bombs, but they were never used. One is tamoxifen. The other is Clomid. And Clomid's only 1 methyl group away from tamoxifen. So tamoxifen is estrogenic with regard to uterine lining. It's anti-estrogenic with regard to everything else, except for blood clots. It acts like estrogen. So it has a mixture of estrogenic, anti-estrogenic effects. But if you pulse patients with tamoxifen, you can make them hyperovulate just as well as you can with Clomid. If you become pregnant while you're taking tamoxifen, you can have an intersex child, which is never very popular. So, if you want to preserve fertility in a woman, and she wants to preserve her fertility, and she's going into a breast cancer treatment, you hyperovulate her with tamoxifen, harvest her eggs, freeze them for use later in case we wipe her ovaries out with chemotherapy. You don't hyperovulate her with Clomid because it doesn't have an anti-estrogenic effect relative to breast cancer's estrogen. So that's the primary difference between Clomid and tamoxifen. All right, for postmenopausal women, we use a class of drugs called peripheral aromatase inhibitors. Estrogen has central aromatase by which it converts dihydroepiandrosterone from the adrenal gland into estradiol. There's another enzyme called peripheral aromatase that occurs in macrophages and primarily in fat cells that converts DHEA into estradiol. So after a woman's ovaries are removed or she goes through menopause, the primary source for estrogen is going to be fat cell conversion of DHEA into estradiol by peripheral aromatase. Postmenopausal weight gain is associated with increased risk for breast cancer. Having said, men have growing breast tissue because their fat cells are converting DHEA into estradiol, so same pathway. This is a class of drugs that block that conversion because they only affect fat cells. They have very, very few side effects, with one exception. They can unmask vitamin D deficiency, so you have to push vitamin D levels up higher so you don't have vitamin D related symptoms. But outside of that, they don't interact with other drugs. They're pretty much safe in pretty much anybody, and if your vitamin D level is high enough, you'll have no side effects from them. But they're very powerful ways of stopping postmenopausal estrogen, withdrawing postmenopausal estrogen from a woman. We have chemo. Cytotoxic chemo reduces the death rate by 1/3. Aromatase inhibitors reduce the death rate by 1/3. Tamoxifen reduces the death rate by 1/4. And then Herceptin, if you're HER2 positive, reduces the death rate by 1/2. And you know statistics, you can't add these all together. But if you're ERPR positive and HER2 negative, you're most of the time going to be treated with hormonal agent only, unless we have some reason to believe by gene array that your tumor is dependent upon a non-estrogen way of growing. If you're ERPR negative, HER2 positive, you're going to get chemo and Herceptin. If you're ERPR negative and HER2 negative, the only thing we have is chemo. You're going to get chemo. Those patients respond a little differently to chemo, but they still respond. Survivorship and prevention. There is a 50% relative risk increase for colon cancer and breast cancer survivors, so you have to screen them more carefully for other cancers, a little higher risk for thyroid cancer. The biggest risk, however, is contralateral malignancy. So, for invasive ductal, it's a 15% chance to have the opposite breast. Invasive lobular, it'll be an 18% lifetime risk. Tubular, which is a low-grade form of ductal, it's 28% to have a contralateral breast cancer. So it depends on what subtype of breast cancer you have, what your future risk is. You can reduce all those risks if you were ER positive by 50% with tamoxifen, or if you're premenopausal, oophorectomy. You can reduce that risk by 80% postmenopausal with an aromatase inhibitor. You can reduce that risk by 95% with prophylactic mastectomy. So, if you start out with high Gale model risk and you have a invasive ductal cancer, and you check a gene test and the BRCA 1 or 2 positive, they may have a 70, 80, 90% risk of having a second and third breast cancer. They're likely to very quickly get to bilateral mastectomy. If you don't have a family history, you might be pretty low risk of having a second event. The other primary difference in the treatment is the recurrence rate to lumpectomy and radiation is 1% per year. So if you live 30 years, it's 30% risk, 40 years, 40% risk. So women in their 20s with breast cancer rarely get breast conservation because that 1% per year, like compound interest, is going to have to catch up with you. On the other hand, mastectomy is a 6% lifetime recurrence risk. So the longer you live, your risk level is capped at 6%, which is pretty good. All right, that covers a lot of territory. Does everybody need to stretch for a minute?
That's
Before we do anything else? Why don't we stretch for 5 minutes and then I'll